Hello, I'm Zubair Nasi. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us today for today's educational activity entitled Creating Action Steps for Linking Underserved Population with Hepatitis C Care. Today's program is supported by an educational grant from Gilead Sciences. Today's activity is also brought to you by CME Outfitters, which is an award-winning accredited providers of continuing education for clinicians worldwide. Today's CME activity is also eligible for ABIM mock points. So make sure you engage in today's event, answer polling questions, submit questions, and provide feedback. Once you complete today's program, be sure to provide your ABIM ID and birth date and evaluation. CME Outfitters will submit your mock points. You can also claim this activity as CME for MIPS improvement activities. So please make sure to participate and provide example of how you will change your practice, and CMEU AO will send you confirmation of your participation, which you can submit to CMS. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they will come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and platforms as well. As I mentioned, I'm Zubair Younasi. I'm the chair of the Department of Medicine and the professor of medicine at the Nova Fairfax Hospital in Falls, Virginia, right outside Washington, D.C. I'm also the president of ANOVA Medicine for ANOVA Health System. Let me first welcome my colleagues, starting with Dr. Barbara Cave, who's the assistant professor at University of Louisville School of Medicine, Christina Lee Brown, Envirom Institute, which is part of Division of Environmental Health. She is the hepatitis C program lead for University of Louisville Hospital Hepatitis C Center in Louisville, Kentucky. Welcome, Barbara, and thank you for joining us today.
Thank you. I'm so excited to be here today.
Thank you. Also with us today is my colleague, Anthony Martinez, who's the associate professor of medicine at Jacobs School of Medicine in the University of Buffalo. He's also the medical director of hepatology at Erie County Medical Center in Buffalo, New York. Welcome, Tony, and thank you for joining us today.
Yeah, thanks for the invite. Thanks for having me with all of you.
Thank you. And finally, I'd like to welcome Christian Rammers, who is the Chief of Population Health and the Medical Director of Laura Rodriguez Research Institute. He's also the ACGME designated IO, Family Health Center of San Diego, Clinical Associate Professor of UCSD, and Adjunct Professor of San Diego State University School of Public Health, and a Senior Clinical Advisor for Clinical Health Access Initiative Global Health Hepatitis Program in San Diego, California. Welcome, Christian, and thanks again for joining us today.
Thank you, Zubair. Good to be with you.
Thank you. Let me now review our learning objectives. Our first learning objective is to apply the CDC's Universal Screening Guideline to use this guideline to improve the diagnosis of hepatitis C and linkage to care. Now, before we move into the data, I'd like to get the audience's input and get you involved for those of you who've joined in. You'll see that the question on the screen, and you'll choose one of the responses. And what we are interested in is to find out how to identify the top 3 barriers to screening patients with hepatitis C. Again, you can choose up to 3 barriers. Your choices are A, limited specialist availability if patients are positive, B, patient fear and misunderstandings, C is stigma associated with hepatitis C. D is asymptomatic disease. And then E, no additional education about who to screen and treat. Let's go ahead and vote now. So great. Now we see the answers. There's probably most folks actually chose number 2 and 3. Actually, also about 62% chose number 4. Let me actually ask you, Tony, the CDC estimates that about 2.5 million people are living with hepatitis C, and only about half of these patients are aware of their status. And those who are treated are nowhere near where we really want them to be. And today's hepatitis C is really not a baby boomer sort of hepatitis C that was when we started this journey, almost a decade ago. Can you just tell us a little bit more about what the data shows and where we are in terms of the problem of screening and the current sort of challenges that we have in this context?
Yeah, so as you said, there's about 2.5 million people still living with it, but half the people don't know they have it. And in part, it goes to what was just on the prior screen. Hep C is often asymptomatic. People haven't necessarily been tested for it, and we failed risk-based screening. So it's like you said, it's not just the baby boomer disease that it was even 5 years ago. The curve's now a bimodal or quasi-modal even, and we have the baby boomers still, but in that 2.5 million people, we have these emerging cohorts like young PWID patients, people who inject drugs, women of childbearing age, children of women that vertically transmitted Hep C, the prison population. So only about 37% of people with Hep C have been taken up into treatment. And that in order to achieve the World Health Organization's targets to eliminate Hep C by 2030, we obviously need to do a much better job. So we estimate that there's, on this slide, it goes up to 2016, and some of the newer stuff that's out, there's about 55,000 new cases of Hep C per year. And most of this is being driven by injection drug use. So the slide, references the opiate epidemic, but really what we're talking about is injection drug use as a whole. So it depends where you are, what part of the country. I know where Barbara is, and even where Christian is, you may see more injection of things like methamphetamine. So really what we're talking about is injection driving these new cases. And we've seen a shift. We've mentioned the shift away from the baby boomers. And where we're seeing this emerging demographic is in that 18 to 29-year-old cohort, with Hep C rates are up 400% in that really important age group. And I think the reason that they're fueling it so effectively is that, they frequently share the implements of drug use. And this is a huge vector of transmission. Hep C can survive not only on the needles or the syringes, but on the implements of use. So we're talking about the cookers, the cottons, the filters, for example. So I mentioned we have some emerging cohorts. The baby boomers still very important. They used to represent about 75% of all people with Hep C. That number's come down. I think it's somewhere about half of individuals. A lot of those folks have been treated. We still have some states that had treatment restrictions, however, and depending where you're at, there still may be large groups of baby boomers that are treatment naive. These young PWID patients, as I said, women of childbearing age. And one thing that's important to point out on the slide is that each of these cohort groups may engage the healthcare system in different settings. So where the baby boomers may be coming into an FQHC or their primary care, young PWIDs may be presenting in the ER. Women of childbearing age may be going to Planned Parenthood or to see their OBGYN. So all of these groups may interact with the system at different places. And that becomes important when we talk about screening and linkage. How we do what we do may be different depending on what cohort we're talking about.
Yeah, that's a really important issue, Tony. And pregnant women who are hepatitis C positive is really an important group. Barbara, you've had firsthand experience in this context with screening a pregnant woman in Kentucky. Can you Can you tell us a little bit more about that program that you're leading and what the take messages would be from that?
Yes, absolutely. I'm so excited to be speaking to this. So Kentucky is the first state in the U.S. to actually have a law requiring the screening of hepatitis C in pregnant women for each pregnancy. Back in 2018, when that became law, we had already started a program at University of Louisville Hospital. And over a period of about 18 months, we had 97 hepatitis C antibody positive women deliver babies. Of them, 92% actually had active hepatitis C infection at the time of delivery. One of our questions was, are there factors associated with women with hepatitis C and linking to care after birth? Linkage to care being interacting with a primary care provider, OBGYN or women's health provider, addiction care, mental health, or a hepatitis C treatment specialist, to see if we could address the problem of hepatitis C, get mom cured before she had any subsequent pregnancies, but also follow these children so that their outcome as far as hepatitis C transmission could be tracked and followed over time. And what we learned was that it really didn't matter if mom had ongoing substance use during pregnancy, which 42% of our moms had reported. It didn't matter if mom was smoking cigarettes still, which 74% of our moms had reported. Or it didn't matter if mom had any history whatsoever of injection drug use. 82% of our moms had that as their primary risk factor. What we found was linkage to care was more predictable in women that had already been engaged in care, and women who were diagnosed with hepatitis C infection at the time of delivery. Those were the moms that were less likely to link into care, and they may have also been the same moms who essentially had no prenatal care whatsoever. So this tells us that we want to engage women across the lifespan, but especially during the childbearing years, get them screened, diagnosed, treated, and cured before any pregnancy. But if we capture them in pregnancy, have a plan for what happens after delivery so that these mothers can still go on and get treated and cured before they have any subsequent pregnancies.
Great. Let me actually, before asking the next step, question is to ask the technical folks that there are some issues in terms of hearing the platform using Chrome. So maybe you can just answer that question for one of our audience who's been joining. Now, Barbara, one of the other issues that Tony brought up, which had to do with the ED and screening and how to really use that sort of environment to improve not only screening, but also linkage together. And I'd be interested to see what you think, because you've been a part of this model, and maybe also bring in Tony and Christian for their insight. Barbara, you can start.
Yeah, thank you. So our experience with pregnant women over at University of Louisville Hospital led us to really want to explore the concept of younger people having hepatitis C. This project started while the main recommendation was to screen baby boomers, but we recognized very early on in Kentucky that we have a substantial injection drug use problem, and that the majority of our newly identified patients with hepatitis C were in a younger cohort. So we set up a program to sort of automate screening, testing, diagnosing, and linkage to care within our emergency department. So patients between the ages of 18 and 45 years old that came into our ED that had blood drawn and answered positively to a risk-based questionnaire were eligible for testing if they had blood drawn. We had just over 12,000 questionnaires completed, and about 25% of them had positive risk indicated. We ended up testing about 1,890, and of them, 36.8% of them had hepatitis C antibody. This is a huge rate of exposure. I mean, just blew our minds to see how many people in this younger birth cohort actually had exposure to hepatitis C. And of them, the majority of them were actually infected with hepatitis C. So if we step back and just look at the number of people coming into the ED in this age group that had the testing done, we had a 23% infection rate. So this just speaks to the importance of really actively seeking out screening and testing procedures for this younger population. Certainly using a universal approach would be best, but this would have overwhelmed our system and the way we set up this program. So we really do recognize, certainly in our area, that this younger patient population, especially the population who may be injecting drugs, is really driving our numbers up in this area.
Barbara, before we actually go to Tony and others about the same issue, one of the viewers is asking about the pregnant patients treatment, and the question, of course, is do we treat pregnant patients or not? If not, then why do we screen? So you can probably just clarify those for our viewers.
Sure. So our program is to screen pregnant women and get them diagnosed, but treatment is generally held until after delivery. Currently, there's no on-label treatment of pregnant women for hepatitis C. It's also not in the recommendations for the AASLD at this time. However, the science is moving toward that, and we do expect within the next several years we'll have enough data to be able to move forward with treating pregnant women during pregnancy.
Thanks, Barbara. Tony, what do you think of this ED issue? You've had a lot of experience, and then maybe Christian, you can also chime in. What do you think, Tony?
Yeah, we were doing this a similar type of program where we were doing near universal screening out of our ER. It initiated with a focus grant, and it kind of just became standard practice within our institution. Unfortunately, COVID's impacted that, and it took a pause. It kind of got deprioritized during the epidemic, or the pandemic rather. And we still haven't fully come on board again with it. We're currently here in Buffalo, we're just in our third wave of COVID. So this was pretty successful though while we were doing it. And I think, you raised an important question that Barbara answered about, even though we can't treat these pregnant women, it's important that we identify them. We have treatment for children indicated down to age 3. So if we can identify those pregnant women, it helps us also to track the children that are born to those Hep C positive moms so that we can get them into treatment as soon as possible.
Absolutely. Christian, any difference in terms of ED sort of screening in San Diego?
No, I'll just add that we benefited from this as well. I think if we're going to get to elimination, the no wrong door approach is really what's going to be needed. Many people use the ER as their primary care, unfortunately, in our healthcare system. And as a community health center or federally qualified health center, we're constantly seeing people for ER follow-ups. So to screen them for hepatitis C just is one other way that they can get linked to care and hopefully cured.
And Christian, the incarcerated population is another very high risk population in terms of high prevalence of hepatitis C. Can you tell us a little bit more about barriers to hepatitis C testing and treatment for those who are incarcerated in prisons?
Sure. So we'll just start with the prevalence. This is the slide says it all, a ghost population that's been really hiding in plain sight. The overall prevalence in U.S. prisons is thought to be about 18%, but the range here from state to state is from anywhere from 12 to 35% seropositive for hepatitis C. And if you look at it a different way, correctional populations actually make up a third of the Hep C cases in the United States. So really a population that is going to have to be addressed if we're going to get to elimination. This is a 10-fold higher rate than the general population. And it represents a missed opportunity. This is it's gotten so simple to diagnose and treat hepatitis C that it's really something that we should be looking into. Unfortunately, to date, less than 1% of people that are in prison receive adequate treatment. And I think there's many reasons for this. The first is the uncertainty of the prison sentence. Prisons are reluctant to start treatment if they don't know when somebody's going to leave. With the regimens being 8 to 12 weeks, though, I think that's a little bit less of an excuse, maybe for jails more than prisons. But in addition, there's a constant churn within prisons, and people are going in and out. And we as community providers really need to link better with prisons in order to get this done. I've been encouraged recently in California that we've seen prisons actually take more of this on themselves, and some of them doing universal screening. Of course, prisons operate as independent entities in many places, so we're not all on the same page, but really a missed opportunity that people, I think, are paying more attention to going forward. So regarding screening, I mentioned this, screening is the name of the game. We talk about a care cascade and getting people screened and diagnosed and linked to care. It all starts with screening. And it doesn't really matter how good our medicines are and how effective they are if we don't identify people largely with asymptomatic infection and link them into care. So there's been some really encouraging news in the last couple of years with different organizations such as AASLD and IDSA first recommending universal screening, the U.S. Preventive Services Task Force also recommending universal screening. And then on this slide, you can see the CDC came in line as well. And I'll just go through a few of those specifics here. That HCV screening is really recommended for every adult, everyone over age 18. And then in addition, as Barbara mentioned, the pregnant population being very important, the CDC is saying each pregnancy we should be screening as well, except in settings where the prevalence is less than 0.1%, which is essentially no state in the United States. So this is essentially a universal recommendation. There's always been a one-time screening regardless of age, setting, or prevalence in some certain specific populations. You can see them listed here. People with risk factors, people with HIV, people with abnormal LFTs that have not been fully diagnosed, and then those that have an obvious exposure, an organ transplant or a blood transfusion. And then what do you do after that one-time screening? Well, of course, routine periodic testing is going to be necessary. And I think these bullet points are pretty obvious. People who have an ongoing risk of hepatitis C infection, whether they inject drugs or share needles, people with certain medical conditions, such as those on hemodialysis. And then, of course, if anybody who asks for an HCV test, they may not be telling you some risk factors, and you should definitely perform it then. So I think this strategy, now endorsed by really ASLD, IDSA, U.S. Preventative Services Task Force, and CDC, is to make screening just a routine part of medical care. And those of us in primary healthcare that are incentivized to do colon cancer screening and breast cancer screening and cervical cancer, this is now going to become something that we need to incorporate into our practices to identify more people.
Yeah, I think just before we leave this subject, there are a number of questions that the audience have. And one of the questions is about cost data and cost effectiveness of screening, say, in ED or OB clinics. That's one thing that we need to address. And of course, the second issue is that how to approach someone in the ED that doesn't stigmatize individuals. And maybe Christian, you can start, and we can ask Barbara and Tony also to give their insight.
Yeah, I think when you make something a standard part of medical care, it automatically destigmatizes a little bit. And instead of having to explain, well, looking at you, I think that you're a person who injects drugs because of the abscesses on your arm, making it something that we do for everyone, that's going to be very helpful for destigmatizing. And then in terms of cost effectiveness, the prevalence that we're seeing in certain populations really, I think, justifies the test. You know, an HIV testing program is considered successful if you find 1% positivity rate. And in ER departments, and then in certain populations in prison, certainly in pregnant women, we're finding prevalences that are much higher than that, which I think justifies the cost.
Yeah, and just to reiterate what you just said, Christian, is that we published something maybe about 4 or 5 years ago to show the cost effectiveness of general population screening, which has much lower prevalence rate. So if you've got a higher prevalence rate and the cost of drugs from 4 years ago have gone down substantially, then it has to be more cost effective to do this. Barbara, there's a question about screening, young women, and whether we should just screen everyone or just screen those who are at risk for IV drug use. And if you follow the ASLD and the CDC's recommendation, anyone who's adult should be screened. Is that your recommendation too?
Oh, yes, absolutely. I strongly feel that any adult should be screened for hepatitis C at any opportunity that they request it, certainly, and then at least once. But you also have to be aware, as young patients are interacting with the healthcare system, they may not have had an exposure or had a risk factor, but maybe 5, 6, 7 years later, they might have a risk factor and maybe need to be retested at that point. So I think it's important that we keep in mind the social history and the developmental history as our young adults go from adolescence into, true adulthood, and some of the risk behaviors that they may have engaged in, whether they're male or female. But certainly utilizing pregnancy is a great opportunity for screening. Not only takes care of that individual mother, but it may also prevent, or at least help us identify any child exposure and give us the opportunity to treat that child before they go on to school. And in kindergarten, they're losing teeth, they're scraping their knees on the playground. They represent exposure risks to other children just in a different way than our adolescents and young adults do with the potentially injection drugs. But we also need to keep in mind there's a lot of unregulated tattooing going on. We live in a day and age where people can buy a tattoo gun on Amazon, they can get their inks, and if they don't understand how hepatitis C is transmitted or how well it survives in ambient temperatures on a number of given surfaces or in things like water or tattoo ink, they may not realize that the risk of propagating the disease is very, very high. So I think it's important we use the universal approach, especially with our young people. But don't forget that you can do this more than once. if you have a good relationship with your patient, periodically ask for social history updates so that you know if you need to have any kind of repeat testing.
Thanks, Barbara. Tony, before we move into the how to screen, do you have any comments about these the screening population and population risk from ED or other sort of milieus or environments?
I think Barbara raised a very, very good point that, this is a move toward universal screening, and it's made it really easy. If you're between these ages, you get a test, a one-time test. But I think that that's the key thing, is that it's not just a one-time test, and it doesn't supplement, it doesn't replace risk-based screening entirely. This is sort of the foundational screening, but risk behaviors are ongoing. They evolve over time as people, as they age, the risk behaviors may change. So I think it's important to keep in mind that this doesn't just replace risk-based screening. This is sort of the foundation of the whole thing, but that's a key piece that we still need to keep in mind.
Thanks, Tony. Christian, let's just now switch gears from whom to screen, and now let's talk about how to screen for hepatitis C. You have a lot of experience and sort of this area. Can you just review that for us?
Great. Yeah, the good news here is this is getting simpler. There used to be another step where we could lose patients between checking for an antibody and checking for a viral load. So hepatitis C is a sort of a unique disease in that not everybody exposed to it goes on to develop chronic infection. And for a long time, we were separating these tests out and losing a good proportion of people along the way. But thankfully, most antibody tests now are actually linked to a reflex PCR. So you don't really have to think about it anymore, as long as your system, and you should probably look in your electronic health record and see what tests you're doing. But most systems are tuned now to do a reflex test. So you don't have to think twice about that second step. But what do you do with a negative test? So this is, a testing moment is much more than just the testing result. It's an opportunity to counsel patients, to take that social history, as Barbara mentioned, confirm that people really know how Hep C is spread and what their risk actually is. And then, of course, offering harm reduction and other services to keep people safe. So it's getting simpler. I think every testing moment should be an opportunity to do more education, more social history. But once you get that test and it reflexes, then you can move ahead with treatment.
Hey, Christian, are there any people who you might see a falsely negative test that may actually have Hep C?
That's a good point. So false negative, I think you're referring to a window period if somebody is acutely infected there. So a false negative might show up if somebody has just recently been infected. I would think of this more in the younger PWID population who may be exposed more recently. In older baby boomers, you're probably unlikely to see that. And just another justification for frequent testing and then retesting in people with ongoing exposure.
That's a very important point, Tony, to bring up. Let's just now move to our second learning objective, which is to really expand treatment for hepatitis C in the primary care setting using the simplified algorithm for screening, treatment, and patient monitoring. When I started my career as a hepatologist many years ago, primary care was not really engaged, and I am delighted to see that this is the only way we can actually address this issue. Now, before looking at the data, let's do another audience response poll. That with the direct acting antivirals, primary care providers are well positioned to initiate treatment. And we're interested to really learning from you and hearing from you, the audience, what barriers you think you're going to face when you think about initiating treatment and hepatitis C. And these are the options you have: substance abuse, patient fears and misunderstanding, limited specialty availability, stigma, concern that patients will not adhere to their treatment, and need for additional education about initiating treatment. Let's select your top 3 barriers and go ahead and vote and see how it looks. So it looks like the option 4 or option D, stigma, is a major issue still in folks' mind. Let's now review some of the treatment that we have currently. We have very effective treatment for hepatitis C. And you all know that unlike HIV and hepatitis C, you can manage HIV very effectively and you can suppress hepatitis B. Cure is not an option for hepatitis B or HIV. Hepatitis C is a curable virus, and with oral direct acting antiviral agents that are broadly approved now, treatment of hepatitis C should become really easy. And as you know, DAs are now approved for even kids of 3 years or older. And your cure rate, which is the same as sustained virologic response, is 98%, and pretty good, very good results in PWEDs, and also difficult to treat individuals, those who have undergone solid organ transplantation or have advanced liver disease. Now, Tony, I'm interested to know that an important factor for both surveillance of HCC and medication selection is staging of hepatic fibrosis. Can you tell us, how do we stage in the context of an algorithm that you can use pre-treatment for assessing and testing? And do we have any non-invasive tests instead of a liver biopsy that we can use to stage these patients? Tony, go ahead, please.
Yeah, this aspect of Hep C management has gotten really a lot easier, much more streamlined. We have this new simplified algorithm that we can utilize for most patients. Hepatic staging's gotten even easier. There's no more liver biopsy involved. It's rare that we actually do that, and in the setting of Hep C, I don't think we do it practically at all anymore. It's reserved for when etiologies of liver disease are in question, for example. So the basic algorithm here is primarily, I bet, what most of you are already doing when you treat Hep C. So these are basic tests, a CBC, a CMP. We're screening everybody for hepatitis B exposure, HIV, and hopefully for their Hep A immune status. Now, if our patient's platelets are over 150,000, everything else looks okay, we can begin treatment pretty much in any setting. We can do this by any type of provider in any, non-conventional setting. It doesn't have to be under the care of a specialist. I think you bring in the specialty management if your patient is co-infected with Hep B or HIV. In those patients who have uncontrolled comorbidities or maybe who have advanced kidney disease, those are patients that maybe you're referring out. Now, there's a couple simple tests that you can kind of look at that will tip you off if your patient's likely to have advanced fibrosis or cirrhosis. And the ones that I like to pay attention to are the total bilirubin, the albumin, the PTINR. That's not on the list here, but pertinent to what's on your simplified algorithm, if the albumin is low, if the total bilirubin is elevated, these are tip-offs that your patient probably has more advanced disease. But the number one test that correlates with the presence or absence of cirrhosis is the platelet count. So if the platelet counts fall in that 100 to 150,000 range, this is your red flag lab test right here. And I think that when you see that, you go right to getting an ultrasound, because the ultrasound will actually do two things. One, it'll confirm stigmata of cirrhosis. So you might see splenomegaly. You may even see some varices or an increased portal vein diameter. These are radiological stigmata of cirrhosis. The second thing that the ultrasound will do, it'll surveil your patients for the presence of liver cancer. So all of our patients who have Hep C that become cirrhotic, and I would even argue patients who have F3 fibrosis, so right on the cusp of developing cirrhosis, should also have an ultrasound or some form of imaging every 6 months to assess for HCC. Even if our patients get cured of their Hep C, the risk that they develop liver cancer doesn't go to zero. So it's important that we continue that ongoing lifelong surveillance. And you can see the stages on this next slide here. Just to make things easy, this is Medivir staging. We break it down into 4 stages. Stage 1 is kind of, you just sort of have inflammation, but there's not any scar development yet. In stage 2, you started to you've started to lay down some of the precursors of scarring. In stage 3, you have more extensive fibrosis. And this is kind of what we have historically considered the point of, no return, where you've really distorted the architecture of the liver cells. Although we have, new evidence that maybe there is some degree of fibrosis regression when people get treated and cured. And then finally, stage 4, this is consistent with cirrhosis. Next slide. So I told you that there was no more liver biopsy, and that's a good thing because, it's an invasive test, and if we can avoid it, we'd like to. So we have a number of non-invasive ways that we can assess for the underlying extent of the underlying fibrosis. So there's something called elastography, and this is, there's also magnetic resonance elastography. That's kind of like an MRI. It's a little bit less widely available. So a lot of you, I think, have probably heard of a fibroscan, and this is like an ultrasound, and it measures how stiff the liver is, and that score that you get correlates with the degree of hepatic fibrosis. That test also tells us how much steatosis, or how much fat, is inside the liver, and you get a corresponding score for that as well. So you get 2 pieces of information when you do a fibroscan. MRE, this is, like I said, it's not as widely available. It utilizes MRI technology. So in my center, we have FibroScan available. We don't have the MRI-based platforms. There's simple tests that we can calculate. We're already getting these baseline labs. We're looking at the patient's liver enzymes. You can take the patient's age and put them into these calculators called a FIB4 or an APRI. These are you can download these apps on your phone, you plug in the information, and then that kicks back a score that correlates with the degree or the likelihood that the patient has more advanced disease.
Yeah, Tony, before we go into the next step, the next algorithm, a couple of questions that are really important to address. One, one of our viewers have been asking, why didn't we have an option about pairs and some of the barriers that they have created? Do we still have those barriers in practice, and is it really a major barrier at the moment?
Yeah, it depends on what state you're in. There's still a handful of states that have restrictions based on the degree of fibrosis. I'm here in New York. We're, a green light state. There's no barriers to who can prescribe. There's no sobriety restrictions. There's no fibrosis restrictions. Some states still have that in play, but you can make that assessment in these easy, non-invasive ways. One test we didn't mention is called a FibroSure, or a fibro test. This is a simple blood test available in all the commercial labs. So you have a number of tools at your disposal where you can make that assessment. As for initiating treatment, I think that, if you get that baseline simplified algorithm set of labs and, you don't see any red flags, you can initiate treatment without necessarily getting a FibroScan, or you don't need to get your ultrasound. So hopefully we can eliminate that barrier, but it does still exist in certain states.
Tony, one other question, which is pertinent to the algorithm that you reviewed. Why not genotyping anymore?
Yeah, so that brings up an important, in a somewhat not really controversial, but there's still some debate about this. Do you even need the genotype? We have multiple regimens on the market now that are pan-genotypic, meaning they treat all the different types of Hep C. So the argument is, well, why do we even need it? And, I think we don't, but a lot of the payers still require it to check off a box in order to get your patient their meds filled. If you have some patients that become reinfected, it may become an important piece of information to know, what your secondary treatment is going to be, or your salvage treatment. But you're right, really, we don't need it. And it's not even included in that simplified algorithm. This is pretty much a simple, 2-horse race between 2 different medications that we have available, Sofvel and GP. Like I said, both of these, and Christian's going to walk us through these in a little bit, but they treat all the different types of Hep C. Pretty simple, you go through this standard dosing, and 3 months after the completion of treatment, you check a viral load to assess for cure. And we want to make sure we use the word cure. Like you mentioned a few slides ago, Hep C is curable. It's not dormant. It's not in remission. We can completely eradicate it. So patient completes therapy. We wait our 3 months. We check a viral load. If it's negative, your patient's good to go. If the viral load turns up positive in that period, or, in the SVR assessment, the viral load's positive, I think that's a good time to consult with a Hep C specialist or your local Hep C champion as to what to do next. And in terms of on-treatment monitoring, there's really no response-guided therapy anymore. In your non-cirrhotic patients who have never been exposed to hepatitis B, honestly, we've initiated treatment and we don't check labs again until we do that SVR assessment. In your patients who have some of these other comorbidities, I think it's different, that those patients may require some labs while they're on treatment. But in general, most of the patients that you're going to see can probably get away without anything until that SVR assessment.
Yeah, that's very important. Now, before we get into the specific regimen, there are a couple of questions. Maybe I'll ask Barbara and Christian to also, sort of participate. And it really has to do with what specifically is the role of PCP. When should they actually, and should they treat HIV, HCV co-infected individuals, decompensated patients? Should they monitor patients for hepatocellular carcinoma or newly diagnosed patients? What are the sort of the lines that you draw to say, well, this is the type of patient that PCP should actually treat, and then the rest of them, more complicated patients, can be referred to a hepatitis sort of expert or an HIV, hepatitis, HCV expert. Barbara, what do you think?
Well, if we want to draw lines in the sand, keep in mind it's sand, we can erase lines and redraw them as people learn. I think primary care absolutely should have solid investment in taking care of screening, diagnosing, treating, and or referring patients with hepatitis C, certainly from stage 0 on to and including stage 3. But after that, that's where it becomes questionable. And I would say it then would turn over to your level of comfort and your level of expertise at that point. Generally speaking, at least 80% of patients that would come through your practice are treatment naive, non-cirrhotic individuals. That's the vast majority of patients. That alleviates those of us in specialty care and so that we can focus on patients with advanced liver disease, concomitant liver diseases like hepatitis B and or HIV infections with hepatitis C, or those patients with liver cancer or maybe severe fatty liver disease or alcoholic liver disease in combination with hepatitis C. It unburdens the specialists to really get into these very complicated cases, but at the same time, it allows you the opportunity to really engage with your patients. It lowers barriers. It's cost effective. It's cheaper for the patient to see primary care than it is a specialist. Chances are you're closer to the patient than the specialist is. It's just all around the way to move forward and do things. It's also going to allow us to reach far more people than relying on specialists alone. But I think I'm preaching to the choir. You all wouldn't be here if you weren't interested in learning how to do this and some of the nuances. The bottom line is, if you're interested in learning it and you have the desire to move forward with it, you absolutely can, and know that you're supported by the experts in the field.
Barbara, do you put other sort of liver health issues on the shoulder of the primary care? Meaning, for example, HCC screening when there's time to screen for esophageal varices, immunization for patients with liver disease. Those are all recommendations by different societies. Or do you think that that's something that should go to a specialist?
I think a specialist should own those inherently, but as primary care providers gain expertise and comfort, if they're willing to take on some of that additional monitoring in an uncomplicated, very well compensated patient, I think they can, and that's my opinion. Now, as soon as somebody's decompensated, that patient's very likely on the path to liver transplant. And at that point, they absolutely should be in the care of a specialist, because there's additional monitoring and considerations and different medications that are considered that really do fall under the care of the specialist.
Great. Christian, let's just now look at some of the regimens. And in order to eradicate hepatitis C, really on a widespread scale, we really need to be able to treat different types of use different regimens, pan-genotypic regimens. And let's just look at the recommendation, at least from AASLD and IDSA.
Sure. So you saw on the simplified algorithm, there's really only two choices. And as Tony mentioned, it's a two-horse race here. But we are really spoiled from 5 years of just an explosion in DAA development. We have incredible tools now, and both of these are fantastic, highly effective, and very safe regimens. So there are some contexts where you won't get necessarily a choice because of insurance restrictions, but both of these are really, really good regimens. There's only a couple of very subtle differences between the two, as you can see in this chart here. The dosing interval is a little bit more straightforward with soft bell, 12 weeks for everybody. And then with glucapavir pebrentosvir, just not really to be used in decompensated cirrhosis. And as we've mentioned in the last couple of minutes, this is really one skill that any primary care provider who's going to be treating Hep C needs to know how to do, which is to diagnose cirrhosis and then to pick up decompensated cirrhosis. The dosage, as you can see, is just slightly different, 1 tablet a day with or without food versus 3 tablets a day with food. The side effects, I think those of us that have been treating for a while know that these are relatively mild and almost always will not be treatment limiting. So very, very few patients will have to stop treatment in order to address these side effects. Most people will just push through it in a couple of days, they'll be gone. But you'll see almost half the table is devoted to drug interactions. So this really is something that we should pay attention to. Anybody that I'm training on how to treat hepatitis C, I make sure that they, before they hand out that first pill or before they write that prescription, do a very thorough drug-drug interaction check, because it's a little too much to keep in your head, in my opinion. So use a tool, whether it's in your electronic health record or the University of Liverpool drug-drug interaction database. And that's really it. And we have fantastic SVR rates with either of these two regimens.
Are there other regimens that are there that may not be as widely used? And we talked about the prison population, and there are other regimens that are available only to them, I guess.
Yeah, there still are other regimens on the market. Some of this gets down more to economics than what we would rather treat. I do a lot of international work, and actually sofosbuvir decladisvir is still one of the most widely used regimens because it is so incredibly cheap. So yes, I'd say, for other in specific contexts, you need to think about other things like genotype specific regimens or regimens that are other than these two. But for the general US population, we're gonna come down to just these two simple regimens.
Maybe we can go next to how do you monitor these patients post-cure? You have an algorithm, and maybe you can review your approach.
Yeah, sure. And this is where, again, one of the essential skills of any Hep C treater is to be able to triage who has cirrhosis and who does not, because really the management is different depending on whether you've made that determination. Tony mentioned HCC screening, really an important part of care. I would argue that a primary care provider who has an interest in hepatitis C can take care of most of those things on their own, but very important to have at arm's length a specialist if they need an EGD done or if they need help with a decompensated cirrhotic patient. We also should always talk about reinfection and other liver disease. So I like to make an assessment really at the beginning of treatment as well as at the end. When we do that SVR12 lab, or if we do other labs and the transaminases are still elevated, we need to broaden our thoughts and think, did we uncover a patient with NASH or fatty liver or some other disease? So harm reduction here, talking about reinfection, making that assessment between whether they need ongoing attention because of cirrhosis or F3 fibrosis or not. And then also that screening piece. If they do need repeat screening, we should continue to do that as well.
There are a couple of questions that I think we need to address. And I think especially this one question from a primary care physician who was in sort of urban community setting. And he's absolutely right. When you actually even refer a hepatitis C patient to a specialist, a hepatologist or gastroenterologist, most of the time they are being treated by our physician extender colleagues, not someone not a hepatologist per se. Although I have to say that my extender is probably a better hepatologist than I am half of the day. So at least clinically. So I think there is a big role to push that primary care physician should treat all hepatitis C patients as long as they're comfortable with treating. And at least that's been my standing. But they should have probably somebody that they can connect with in case there is some idea, so there is some possibility of really very decompensated patients that then would require the other standard of care for treating advanced liver patients, which is really liver transplantation and management of liver cancer. Yeah. There is a question about PROs, and I'll tell you because I've done a lot of the PRO data assessment myself. Yes, there is plenty of publication that if you cure patients with hepatitis C, the patients with mild disease, their PROs improve. The patients with advanced disease, their PROs improve. And then now there is up to 5-year follow-up that patients that are cured, even those that have cirrhosis, not only their clinical outcome improve, meaning that they will have less complication of cirrhosis, but their PROs continue to improve over time. Now, if you have more advanced cirrhosis, you will improve, but liver disease will still have some impact on quality of life and other patient-reported outcome. Another question that I think is related is to the fact that why do we have to do genotyping? And I think Tony already responded to that really you don't need genotyping, but you are sometimes required genotyping because of payers and their request to have genotyping. Tony, back to you about patients with kidney disease and end-stage renal disease. Maybe you can tell us a little bit more about what considerations should we have when we are treating these patients.
Yeah, this used to be considered a special population, and it's kind of not the case anymore. Both regimens that we have available to us for most patients here, they're both indicated in patients with end-stage renal disease, including dialysis. So, this was a population that in the past, they had really limited options for treatment. And ironically, they were it's a disproportionately affected group, having never been on hemodialysis as an independent risk factor for Hep C. So all of these patients now, they do have an option for treatment. The outcomes are identical to somebody who doesn't have end-stage renal disease, and the algorithms of care are identical. One thing I would mention about the genotyping thing, I forgot in my response to it before. In a lot of places, we talked about reflex testing for Hep C antibody that reflexes to the viral load. A lot of places, including my institution now, we actually reflex the Hep C viral load to genotype. So we have taken out of our EMR the ordering of the Hep C genotype in and of itself. So now whenever we get a viral load, if it's undetectable, they just don't run the next piece of it. But we're actually using reflex testing both for antibody to RNA confirmation and also RNA to genotype. So that is something that's out there and available to folks.
Tony, let's talk a little bit about drug safety and drug interaction. And maybe also in that context, there's also a question that we could expand what we have seen in the clinical trials, both in terms of efficacy, and safety from clinical trials to the sort of real world practices. Do we have similar efficacy? Do we have similar safety, similar adherence in the real world setting?
Yeah, so Christian, he brought up a great tool, the hepdruginteractions.org. It comes as an app now. That's a great resource. There are some things that you need to be aware of with statins and PPIs and so on. So that's a great tool. Specific to a lot of patients that I see, and I know that Christian and Barbara see, these PWID patients who are on OST or MAT, they're synonymous depending, where you are at. But we're talking about things like buprenorphine, methadone, naltrexone. So, in the old days, there were potential interactions with things like ribavirin and maybe interferon. But with these newer agents, you can see that the majority of these boxes here are green with a check mark. We mentioned older regimens, Elvisvir, Grazoprevir. This is known as Zepitir. We still see it sometimes being used in the prison population. But the point of the slide here is that there's no interaction with any of these medications, these Hep C medications, with the medications that are used for opiate substitution or MAT. Sofvel and the soft-containing regimens you see there are in a yellow box where there's a potential interaction. We've treated a couple thousand patients in my clinic, La Bodega. They're all on some form of MAT. Most of them are on buprenorphine, and we've never seen any interaction. So that's just anecdotal there. But the important thing is that there's no interactions, no significant interactions for any of these medications used for MAT.
Now, two other issues that's come up in the question side of things. One is the reinfection rates, and we're going to talk about that a little bit more in detail later. But also in terms of retreatment of patients who have failed regimens. Can you just talk about at least the sort of those who are relapsers or get reinfected or fail a regimen?
So look, reinfection is really a failure of harm reduction. And we know that overall, if patients maintain their OST or MAT with no interruption, and we're able to stop their ongoing use, that the risk of reinfection is somewhere around like 1.5%. It's exceedingly low. Reinfection is going to happen. You know, addiction is not a disease that you cure. It's a disease that you manage, and people relapse. I mean, it may happen. Ideally, we provided all the harm reduction that in the event that a patient does relapse, they know what to do and they know how to do it in a way that's safe to prevent Hep C reinfection. But this is something that's been in the narrative for a long time. It's really unfair. I don't know that we lecture patients with other disease states the same way we do people who have Hep C. You know, when you readmit somebody 10 times for CHF, you know, do we tell them you're only going to get one round of treatment for your CHF, so you better adhere to that diet? No, we treat them with their diuretics. We put them in the hospital as many times as we need to. So, you know, when you look at this data historically, it's pretty low. And I would argue that if you're treating Hep C and you have no reinfection, you're not, you know, treating the patients who are the hardest to reach, the ones who spread. You know, so reinfection happens. So what? You know, there's treatment options dependent on the genotype. If you can use, sometimes we use the same regimen, sometimes we use a different one depending. That's where the genotype can be helpful. But unfortunately, this is something that still hangs around the narrative that I would like to see us start to kind of get away from.
Yeah, great. Barbara, we've looked at the issue of the demographic changes that has happened in the United States over the past 15 years or so, and we're looking at younger and younger patients. Can you tell us a little bit more about treating patients who inject drugs, and what are some of the barriers to treatment?
Sure, absolutely. But first, I want to make it very clear that people who inject drugs may not just be our younger population, although they tend to be our younger population. Clinically, I've treated people in their 70s that still have ongoing active heroin use. But generally speaking, our people who inject drugs are this younger cohort of people, and they do represent a very high burden of new cases, and they are substantial spreaders. So they represent one of our highest priority populations because of their ability to transmit the infection over and over and over again. It ends up being this big mushroom cloud of transmission if harm reduction measures are not put in place. So they need to be our priority patient population that we aim to treat so that we can help mitigate some of this spread. But that can't be done in and of itself. We're not going to treat our way out of this problem. This hepatitis C problem amongst people who inject drugs needs 3 different prongs. It needs treatment, absolutely, to eradicate the disease from the susceptible population. But it also needs harm reduction, such as syringe exchange. If you're supplying sterile injection supplies, there's no virus in sterile equipment to be propagated to the next person. So harm reduction strategies, including syringe exchange program, or information on how to sterilize used equipment, or information on how to avoid sharing or limit sharing, or proper disposal of used equipment. All of that is very, very helpful. But the third arm would be medication-assisted therapy. As Tony's discussed previously, we know that there are no substantial drug-drug interactions between the hepatitis C medications and medication-assisted therapy. Incidentally, we know that there's not significant drug interactions between illicit or street drugs and hepatitis C treatment as well. But if we're using the 3-pronged approach of medication-assisted therapy, harm reduction, and treatment, we stand a really good chance of eradicating hepatitis C in this very important population. It's also important to understand that the younger population are still actively spreading it, but our baby boomer population, they were once the young people who were injecting drugs, getting tattoos. They also had some healthcare exposure through blood transfusions, dental work, surgery, and other exposures. Our baby boomer population, they're important and they're a priority group for treatment, not because they're spreading, but because they're getting cancer, their liver cancer, they're getting decompensated cirrhosis, they have very advanced disease at this point. They've just aged out, but they're not spreading. So they're both very important groups to treat and really focus on, but for different reasons. But treating people who inject drugs absolutely needs to be the top priority because we need to stop spreading this curable disease, and we have the technology and means to stop transmission through harm reduction approaches. There are several studies that do show injection drug risk taking behaviors do change once someone's been diagnosed with hepatitis C and has started DAA therapy. People tend to inject fewer times per day. Their injection drug networks tend to be smaller, and they're more likely to utilize sterile injection supply, whether that's through syringe exchange program services or they have other ways of acquiring sterile injection supplies. So it's all very, very important to getting on top of hepatitis C and bringing down the new infection rates and also working toward elimination in this specific population. But there's a number of barriers that exist with hepatitis C treatment uptake amongst this particular population. Certainly stigma, which when we asked our question earlier, this group brought up stigma as one of the biggest barriers, and that's absolutely reflected in what we see here. People who inject drugs bring in self-stigma. They feel defeated. They are beating themselves up. They feel less than, non-human. They're very, very upset with themselves. But then you pile on top of that maybe stigma that the healthcare system may apply to them as well. They come in with their own stigma and expect to receive stigma. So it can end up being a very self-defeating cycle. So it's very important to understand that that patient feels especially vulnerable when they're coming to you for hepatitis C screening and or treatment. Sometimes patients are just unaware of how this virus transmits. I can't tell you how many times I've heard patients say, oh, I gave it to myself. No, you didn't. This is a blood transmitted disease. You got it from someone or something that someone else had touched. So helping to understand the transmission cycle and the fact that it's curable helps reduce some of these barriers and gets the patient interested in treatment, and it empowers them to be able to help control spreading any infection, but also raising awareness amongst their peers, which is also very, very important. Lack of stable housing can sometimes be a barrier for patients because they're worried about their medications getting stolen. It's one thing to have controlled use, have access to syringe exchange programs, have good health literacy, but if you're in an unstable environment, that risk of medication theft or loss or destruction becomes something that may keep someone from getting their treatment in a short period of time. In terms of providers, there's often a lack of understanding. Primary care providers may not realize that we can treat people who have ongoing substance use disorder. They may not realize that that these medicines have no interactions and that it's actually a very easy thing to do if you're willing to interact with the population. And there's numerous systemic level barriers to treating people who inject drugs. A lot of that's just our built-in unconscious biases, health disparities, lack of access, lack of willing providers to take care of it.
Barbara, that one question that came up has to do with, any other social stigma that could be related to cultural issues, say, in Latino or African American population. Is there a specific sort of approach that you would recommend to address those potential barriers?
Yeah, absolutely. One of the biggest things that I like to implore in my practice is using person-first language. I try and be very conscientious about how I'm addressing the individual in front of me and how I document their story in the chart as well. I don't say drug addict. I say person who uses drugs. I don't say clean or dirty. I say abstinent or sober or pause of use or controlled use. I try and just be very conscientious about how these people are addressed in my office, and I try and be very welcoming. I'm sure Tony has other tips and tricks on how to address this population, but maybe in the interest of time, we may not be able to get into that. But there's a lot of stigma surrounding this group of individuals, particularly.
Let's just skip the next slide and go to the HERO study. And Christian, can you tell us a little bit more about this study and how the clinical model might work?
Sure. So I think we've identified that reaching into these populations of people who inject drugs is extremely important. And there have been some investigators that have really explored different ways to successfully treat these populations. And this is some work exploring really different models of care, of how to treat these people who may not really be best served by the traditional primary care, referring to a GI doctor and getting their Hep C treated. So this was a study that was conducted in 25 centers actually throughout the United States, and patients were randomized to a different model of care, one being modified directly observed therapy and the other being patient navigation. Really, a really simple but ingenious way to address adherence challenges. Patients that are in opioid treatment settings. Why not just do a modified directly observed therapy? They're getting their methadone or their other medication in that way as well. And then patients were given sofosbuvir velpatasvir and essentially followed up through a relatively simplified algorithm through the end of treatment, and then SVR12 was looked at as the primary endpoint. There were some secondary endpoints looked at in terms of differences and factors associated with treatment initiation, adherence, and completion. On the next slide, you can see the cascade of care, and we're used to seeing these immense drops from those that were screened to those that were finally treated. And I think what should be impressed upon the audience here is that getting to 50% towards the end is actually quite an achievement, especially in this population here. What the authors demonstrated here is that there really wasn't a very significant difference between the two models, either a modified directly observed therapy or patient navigation. And at each step, we'd lost about 20% of the people. So, this is it's not a completely clean population. We all know that, those of us that treat this population, but really getting 50% of those cured who were enrolled is quite an achievement. On the next slide, they have very detailed adherence data. And you can see that in the opioid treatment programs, you have maybe a little bit of an increased adherence in those that had modified directly observed therapy. But then they also had community-based clinics, and this gets to the idea of bringing treatment to different settings. Treatment adherence does tend to drop off slightly as we go a little bit further over to the right. But overall, really different models of care work for different people, and this demonstrates that even in previously thought of as hard to treat populations, you can get to a cure.
Thanks, Christian. Tony, there are lots of concerns about reinfection in the PWID population as well as treatment adherence. Maybe over the next 3 slides, we can address both the reinfection as well as the issue of treatment adherence.
Yeah, so this was a simplified trial. This looked at about 100 patients with soft VEL. Adherence was monitored and assessed, and they also looked at outcomes. And the overall cure rate in this population, these were people who had actively used within the past year. And some of them had been using daily for the past 30 days. And the overall cure rate was 94%. And 96% of these patients had over 90% adherence. And then you can see additional data on the next slide. When we looked at treatment in PWID, this was with GP, and this looked at over 2,200 people. And these were patients that had a history of opiate use disorder and that were on OST. And you can see here that the adherence rates were 98% of among people who were on OST and 99% among those who are not. So it kind of just demonstrates that not only are they adherent, they're highly treatable, highly curable. In my own clinic, the current SVR rate right now is at 98.6%. And the adherence rate, we've assessed it with the PWID population versus the general population. And it's about 85% in the PWIDs is compared to 75% in the general population. And then we've mentioned reinfection. We've talked a little bit about this. We've touched on it before. This, in my opinion, is probably the most important study out there right now in relation to this issue. This is a meta-analysis, 36 studies, and you can see overall it was about 5.9 per 100 person years, but then it really gets stratified down. And I think that the key thing here is the bullet on the bottom, where the reinfection rate, as I said, was only 1.4 per 100 person years among people with uninterrupted OST who had no recent drug use. So really, I think that this just demonstrates, again, like I said before, reinfection is often a failure of harm reduction.
Yeah, thanks, Tony. Let's just move to the third and the last learning objective that we have that has to do with disparities in treatment of hepatitis C initiation in the underserved rural or federally qualified health centers. And before this, let's just take one last poll question. And this has to do with people who inject drugs frequently do not receive highly successful DAA treatment. And this is because A, DAA regimens are lengthy and complex. B, HCP may not offer HCV treatment for fear of non-adherence, reinfection, or resistance to drugs. And C, people who inject drugs do not have the same cure rates. And last option is people who inject drugs have high rate of reinfection after treatment. Let's just, let's actually take the poll. So most of the, of course, folks chose option B, which is the that may not offer treatment for fear of adherence, non-adherence, and reinfection. Barbara, what are some of the other barriers to treatment, and how do you change this narrative? Maybe you can address that.
Well, I think our audience really nailed it, where a lot of the barrier really just came in from the provider perspective, just under false assumptions or just data that's not data, it's just imagination, right? It's our stigma, it's our unconscious biases coming to light, where we think people who inject drugs can't adhere to a regimen. Data says they do. Well, there's no way their cure rate's going to be the same. Data say it is. It's really neat to know that these direct-acting antivirals don't discriminate. It doesn't matter your age group, your gender, do you have diabetes, do you have high blood pressure, what's your fibrosis stage? None of these factors matter. The direct-acting antivirals as a whole really work very, very well, even in our population of people who inject drugs. It's really getting our healthcare providers activated and initiated in addressing hepatitis C in this particular population. We know that DAAs are not complex. It's one pill once a day or 3 pills once a day for 8 weeks or 12 weeks, and it's very, very straightforward. The lab workup is even streamlined at this point. So we're at a point where, rather than getting hung up on aspects of treatment in individual populations, it's really how do we bring the treatment to our populations. And so there's some alternative models and new healthcare delivery models that are out there that are really changing the approach and how patients will access hepatitis C screening, diagnosis, and treatment, especially for underserved patients or underserved populations with hepatitis C. So we want to change the narrative around hepatitis C. I'm hoping that after you've viewed today's presentation, you really find opportunities to act. These people are at your fingertips. They truly are, whether you've been looking for them or not. It's very important that we stop with the patient blaming. Well, that patient uses drugs, so they can't do this. The patient's using drugs, so they're not going to keep their appointment. The patient this, the patient that. No. It's our time to love everybody. Bring people back into the fold, and maybe consider bringing our offices into non-classical settings. Maybe it's our time as healthcare providers to go to where our patients are. We certainly have seen a lot of removing of restrictions to access and initiation of treatment of hepatitis C along the way. Maybe it's time you sit back and look at your individual state and really figure out what are the Medicaid rules for prescribing hepatitis C treatment in 2021, because they have changed. In fact, 2021 is really one of our first years where restrictions are almost all gone across the US. Yes, there are still a handful of states that have some more harsh restrictions, but generally speaking, many of our patients are going to have unprecedented access to hepatitis C care and treatment than they've ever had before. So if you've not taken the time to learn what the regulations and requirements are in your state, I strongly encourage you to do so. Please remember to incorporate harm reduction into your clinical practice and teaching, because without harm reduction, as Tony says, reinfections are going to be a failure of harm reduction. If we don't provide information to our vulnerable populations, which includes people who use drugs, on how they acquired their infection in the first place and what they can do to avoid a reinfection down the road, we're not doing them the full service. We need to make sure we know where the syringe exchange programs are in our communities. And if there are none, we need to know about the rules and laws surrounding sterile syringe prescribing. How do people who inject drugs get their sterile supplies? There's many modalities, and I'll tell you, Amazon can ship these things across state lines if it comes to it. So be creative, know what your resources are in your area. It is a time where we offer on-site testing. You can screen for hepatitis C very easily at the point of care. And we're hoping to move forward to do not only point of care screening, but also diagnosis. And this can be done out in the field, under a bridge, at a homeless camp. It can be done at the community health fair. It can be done in the church. It can also be done in our emergency departments. But we want to make sure we're offering plenty of opportunities for screening for hepatitis C to help normalize the conversation, but also help raise awareness that this is a completely curable disease. People do not have to walk around with this condition and its long-term consequences. And ultimately, we're hoping to move toward a single visit screening, diagnosis, and treatment visit. This is where the field is heading. We're not quite there yet, but we are rapidly heading in that direction. And you all as primary care providers have the opportunity to be part of that. by learning how to do the hepatitis C care continuum and working with your leadership, your policymakers to help reduce access issues, to help increase access to treatment, to help increase the number of patients that you're interacting with throughout the whole care continuum.
Fantastic. Thanks, Barbara. Tony, maybe you can just actually review the sort of simplified reflex testing and treatment, and also give us the best practices as we are moving into sort of the new steps that will be the future of, as Barbara just delineated.
Yeah, like Barbara just said, I think that, the goal of this whole movement is to get to a place where we're doing test and treat modalities in our clinics. So like we've talked about reflex testing for antibody, for reflex to genotype. This is available. We have pan-genotypic regimens. We have simplified algorithms. We can get you initiated on treatment, do blood tests one more time to confirm cure. So we're really moving toward a rapid implementation of treatment and short treatment courses, and take patients through the journey in the quickest way that we can. We have cure rates that exceed 95%. We have a number of different evidence-based practices. There's a lot of ways you can do this. The 3 pillars of Hep C eradication include screening, linkage, and treatment initiation. And how we do that isn't going to be any one approach. It's going to be a mix and match approach based on settings, who's treating, how we do each thing within those pillars may differ. And I think in the next few slides, you're going to see a number of different models where these have been successful. Yeah,
no, that's absolutely true. Maybe Barbara, you can tell us about the model, that the Kentucky Hepatitis Academic Mentorship model that you have developed to really, address the issue of hepatitis C in the Appalachian areas. So maybe you can actually tell us a little bit more about that program.
Yes, absolutely. I'm very excited to be part of the CAMP model. The Kentucky Hepatitis Academic Mentorship Program was born in 2018 in response to recognizing the growing populations of people who are injecting drugs, the growing populations of pregnant women, the growing populations of hepatitis C exposed children that we have here in Kentucky. In 2018, we had a lot of restrictions removed surrounding prescribing of hepatitis C treatment medications. We looked back, we being the specialists, we realized there's only about 12 centers in the whole state that are able to treat and cure hepatitis C. And we thought, we need help. There's no reason we should be doing this on our own. The treatments are so simple. The workup is becoming so streamlined. It's really time that we engage not only our primary care providers, but any interested addiction care provider, women's health provider, any type of medical provider that has an interest in screening, diagnosing, and curing patients as they are, where they are in their local areas, because there's just not enough specialists to get the job done. So CAMP was created in 2018 as a mentorship, a telementorship program with also peer-based mentoring. And we've now trained over 300 providers throughout Kentucky and have expanded this model to other states. Our ultimate goal is to increase the health of our underserved populations by bringing hepatitis C care providers into high-risk, low-resource settings, including our rural health areas. And we are having wild success. In the 2.5 years this program's been going on, we've had over nearly 2,000 patients treated. We don't even know how many patients have been screened for hepatitis C because we don't track that metric. But we're having wild success with this particular model. And it's meant to be as a supplement or an alternative to other types of models out there, which Christian will talk about his decentralized model here in just a second.
Yeah, Christian, that actually is a great to you. Can you talk about the hub and spoke model that you've been working on for a while?
Sure. So a couple of years ago, all of the liver societies got together, and I was fortunate to be part of this declaration that we really need to integrate hepatitis care, we need to decentralize, and we need to task shift. And that's kind of the approach that we've taken in San Diego. I work in an FQHC where there's lots of primary care providers, nurse practitioners, physician assistants. And so this is just documenting our experience here. About 1,200 patients. We wanted to sort of just to look at whether the effectiveness being treated at the hub was the same as being treated at the spokes. This is based on a model called Project ECHO, which was pioneered by a hepatologist, Dr. Sanjeev Arora in New Mexico, really with the same thing, having an academic medical center at the middle, and then lots of spokes to extend the reach of hepatitis C care really to harder to reach in more rural areas. One other element that's really key to this is these green ends here, which are the patient navigators, really to just be that presence to guide patients through. And this is our team. You know, treating and curing Hep C and eliminating Hep C is certainly a team sport. So that's me, the red ID doctor in the middle. We're fortunate to have a hepatologist, Dr. Carrie Frenette, that helps us out as well. But really, the bulk of the work is done by the primary care physicians, these PMDs or nurse practitioners that you can see scattered throughout 9 clinics, which really increases our reach throughout the San Diego region. On the next slide, you can see kind of our results. And I want to show you that the hub has gotten actually less busy the further along we've gone. These green squares are the hub treatment volume, and you can see that's really fallen at the inflection point of 2016. And the spokes are stepping up and treating more people. And the combination of the two has actually increased our volume overall. On the right-hand side, you can see me as that red square there, the ID doctor, really busy up until 2016. And thankfully, the team has really, taken on some of the work, and those blue triangles, the primary care providers, as well as the purple circles, the nurse practitioners, are treating more and more. So really, it's a team sport. All together, we're having higher and higher cure rates, and you can see those overall numbers, the black crosses there. The total numbers are really, up to 350 patients a year that we're treating and curing.
Fantastic. Last but not least, Tony, La Bodega program in Buffalo that you've been leading. Can you tell us a little bit about that program?
Yeah, so the bodega, it's really like a series of micro models of elimination under one sort of global macro model. And we utilize a number of different modalities, like I've emphasized before, no approach is the one that's going to do it. You have to, Christian mentioned this, that you kind of have to go through all the doors, right? So by any means necessary. And that's kind of how the bodega works. So it's conventional referral systems. It's co-localization, meaning co-management of the Hep C and the addiction on site. We've also implemented telemedicine. We've done that with COVID, to facilitate linkage. And part of what we do is we saw a slide with 3 big barrier groups. So we need to overcome those patient-based barriers. That involves education. That might mean system navigation, so coordinating transportation or facilitating the linkage so patients don't need to make the appointment for themselves, and referring providers don't have to fax things. It means provider education. So we now have our residents, our addiction medicine residents, our ID residents. They rotate through the bodega, and it gives them a lot of experience, not only with Hep C, but also in how to manage people with addiction disorders. So really, this is a mix and match approach. We do about 6,500 visits a year, and it's a small team. And the heart and soul of this team really is our case manager and our social worker, who really kind of quarterback this entire effort. And you can see on the next slide some of the outcomes. This is just a sampling of some of it that we put out there. We looked at some active users. These were patients that were fairly heavy active injectors that underwent treatment. You can see the SVR data of patients who we had the SVR data available at the time of this. It was 99%. The overall adherence was 87%, and there were cases of reinfection. All of those patients got retreated. We had a detox model where we screen people who are coming into the detox. They have that reflex testing that occurs when they come in. We had a handful of those patients that we looked at that we began treatment with. And of the 17 that we identified through that model and started on treatment, they all got cured. With telemedicine and COVID, we initiated this very recently. We had no infrastructure, about 750 visits that by the end of the second week of the entire program, we had converted to video. And what we were able to do was evaluate 51 patients who were newly diagnosed and referred with Hep C. 84% of those patients initiated treatment. They've all been cured. Some of those patients we never met in the clinic. They finished treatment, they had SVR assessment, they never came in, the whole thing was done over telemedicine. And one of the key things that we did find with telemedicine was that it facilitated linkage, but it did slow down that care cascade. So what we might do in a week in the co-localized model maybe took us 30 or 45 days to do via telemedicine.
Well, this was a fantastic discussion. Thank you, Tony, Barbara, and Christian. I certainly learned quite a bit from the three of you. Let me just summarize for the audience what we have talked about. Align screening protocols to updated CDC guideline to ensure that all adults are screened for hepatitis C and are linked to care when it's really necessary. This was a dream of ours, 10 years ago, and it's now reality. Provide successful screening and care continuum with PCPs, really at the heart of all of this, but also other non-specialist providers, and connected to the hepatitis C experts when we need them. Initiate treatment in the primary care setting to expand access to treatment of hepatitis C cure. And then finally, adopt new healthcare models, as we were just hearing from Barbara, from Christian, and from Tony, to expand our opportunity and to really meet the changing hepatitis C landscape. We've had a number of questions throughout this discussion that we've answered most of them. I'll just address two questions. We only have a couple of minutes left. One that had to do with NASH and hepatitis C and diabetes and hepatitis C. This happens to be my area of experience. Yes, you can see NASH and hepatitis C because remember the NAFLD, non-alcoholic fatty liver disease, affect 25% of general population. So it can also affect patients with hepatitis C. And if you have both of them, think about alcohol and hepatitis C, more progression. Same way, if you have hepatitis C and non-alcoholic fatty liver disease together, you can have more progression. These patients should be treated without any reason to worry about their fatty liver disease. And of course, diabetes has been one of the other complications that could be driven in some ways by the virus. And it seems that if you cure hepatitis C, that diabetes may also improve. There are a number of other questions that unfortunately we are out of time. Let me just review to receive CME or CE credit for today's program. Please complete the post test on your screen and then click on the request credit tab to complete the evaluation and print or download your certificate. Visit the Liver Disease Hub for additional activities across liver diseases, as well as resources, animations, and other patient education material that's available. So with that, I want to again thank our panel of colleagues who provided a fantastic opportunity for us. I want to thank you all that you've joined us, and also thank the CME Outfitters for putting together really a fantastic program here. And I wish you all a wonderful day wherever you are, and hopefully we'll see you in the next program. Thank you.